Good evening. Welcome to Adolescent Substance Use Cases and Conundrums. I'm Karen Koch, the Director of Mental Health Education at Eastern AHEC. This webinar series is part of our Child Mental Health and Primary Care statewide project funded by NCAHEC. This funding allows the series to be offered free to participants from across the state. So without further ado, it is my pleasure to introduce Dr. Jason Cho. He's a medical instructor in the Department of Psychiatry and Behavioral Science at Duke University School of Medicine. He received his undergraduate degree from Harvard University. He received a master's in fine arts from Ohio State University, and his medical degree is from the University of Toledo College of Medicine. He completed a child psychiatry fellowship at Duke University Hospital. Welcome, Dr. Cho. Thank you so much for being here.
Thank you so much for inviting me, and I'm really excited that you're all interested in this topic because I do think right now, especially with the context of COVID, it's been an extremely important area to think about in terms of adolescent mental health and child mental health. And so just to review the objectives broadly, this first objective is related to kind of scratching the surface regarding the interpersonal aspects of a therapeutic alliance. That in mental health, we put a lot of emphasis, whether it be a psychiatrist or a therapist, on the therapeutic alliance, and especially in things like sensitive topics like substance abuse, that can be really important. And then the second objective, we'll be talking about pharmacological interventions, and then the third will be non-pharmacological interventions. So my hope is that we can glean some and identify some of these aspects that could be important and helpful clinically. In terms of disclosures, I have no financial or non-financial disclosures to make. And then just to give a context of the sort of outline of the talk today, I will be spending some time talking about the adolescent mind, just as a backdrop for when we're talking about adolescent substance use disorders. We'll talk about some practical clinical concepts. And when I say practical clinical, I mean that these are things to be thinking about in terms of designing interventions or assessing what's going to be a helpful intervention. And then lastly, because it's super important, especially in continuing education, to make any knowledge applicable, we'll be really spending a lot of time working in cases, some real cases from my clinic that can exemplify or be examples for some of the principles we're speaking about. So the first idea of the adolescent mind, just recognizing that certainly adolescent substance use disorders or adolescent disorders in general are are different in that they're occurring with adolescents. And then when we talk about the adolescent mind, we can talk about a really special stage of development. And part of it is being that there's, our brain is developing at different rates, and different parts of it are developing at different rates from other parts. Part of that then looks like there's a higher weight put on novelty and reward. So reward systems are really relevant. However, there's also a lower weight regarding consequences. And in more than just anecdotal experiences, I imagine that there are many parents of teenagers and adolescents here in the audience. There's also actual biological data to support this, or studies that kind of support that this is happening for neurological and biological reasons. This cartoon, which is adapted from Dr. Kuhn's paper about the emergence of sex differences in substance use for adolescents, kind of illustrates this like differences in the rate of growth and development of adolescents' brains. So for this cartoon, we see the blue line being the amygdala in terms of the volume of percent approaching adulthood. And so even at age 14, it's 98% or 97% maybe based on this cartoon of that volume in place, the percentage of an adult. And then the accumbens, which is really related to reward pathways, we see also actually very early on volumes that equate to close to adulthood. The green line, which is way slower to ramp up and then quickly accelerates, is about the cortex. So our cortex, which we describe as the higher mind, the modern mind, is different from the lizard brain or this other aspects of the brain. The house of reason, the house of planning. So this is what's slow to develop. And so again, this being a model for why is impulsivity perhaps more relevant in adolescence? Why is it that rewards are actually more weighted than consequences in adolescence? Could be an illustration of that. Another related cartoon in many ways by Mills just kind of expands it beyond just adolescence. And so seeing this this mismatch. So we have subcortical regions that we also already mentioned, like the amygdala and accumbens, and then these prefrontal regions. So prefrontal cortex being a bit even more specific. that they relate to inhibition. Like, is this a good thing to do or not? And again, seeing this differential rate of growth. And what I love about this in terms of like the calculus of it, right? There's this area underneath the curve, and we can actually pinpoint where is this gap or this area the greatest, which then represents the vulnerability in terms of decisions or in terms of having this mismatch. And so I've talked about it in some ways as this like risk or this vulnerability. I also want to give credit to there's other ways of thinking about it. And so this book, Brainstorm, The Power, the Purpose of the Teenage Brain, is by Daniel Siegel, who's a child psychiatrist. He's published several other layman's books about parenting and about development. And so this one, I invoke this because it really highlights the fact that we can see adolescence as this really important thing, not just sort of a liability or a vulnerability. And just to read from the quote, the adolescent period of life is in reality the one with the most power for courage and creativity. Life is on fire when we hit our teens, and these changes are not something to avoid or just get through, but to encourage. Brainstorm was born from the need to focus on the positive essence of this period of life for adolescents and for adults. It's something that I've actually given to parents of children to give them some better context and some understanding. In this book, or in the principles here too, is a very good sort of child psychiatry ethos that I like to bring into clinical appointments and clinical relationships quite a bit. This idea of, in some ways it's normalization, but this idea that what is a vulnerability is also meaningfully the same, like the other side of the coin of something that's actually super, super important and super valuable. And then in some ways, what when we're talking about things in pathology, really we're talking about something that's fundamental, that maybe it's just a difference of dose rather than something that needs to be erased or removed. Even anxiety can fit that category, right? So anxiety is something that's really important for us to be careful, to think about consequences and to plan and to have us be attuned and alert. However, like a portion of salt, if anxiety is overwhelming, if we have the whole salt shaker in the soup, to mix a bunch of metaphors, then anxiety is a super barrier, super disabling. In any case, when we talk about the teenage brain, we can think about this as both the power of it as well as some of the vulnerabilities, perhaps. The essence that Daniel Siegel brings in that quote, he describes as actually an acronym to kind of push his argument further, that ES of essence is the emotional spark that characterizes adolescence. SE is a social engagement, N is a novelty seeking, CE is the creative exploration. And so I do think about having the idea of the teenage or the adolescent brain, recognizing its magical period, recognizing it's super essential to the full actualization of an adult, having this be the backdrop for thinking about risks and vulnerabilities, that these are also occurring in a fundamental period of exploration, that if we did not have, it would be hard to become a full adult. When I think about clinical themes, we'll go through these different aspects. And again, to repeat myself somewhat, I hope that these can be ways to guide and inform our assessments and interventions. And so the first being comorbidity. When we think about comorbidity in substance use disorder in adolescents, several meta-analyses have suggested that it's actually there's a high level of comorbidity. So these two papers that I've cited here point to 61 to 88% of teenagers with untreated substance use disorder have a mental health diagnosis other than substance use disorder. The Armstrong-Costello article, Costello being a Duke epidemiologist for many years, kind of elaborates further that in interesting ways that conduct disorder and ODD were actually the most commonly associated with substance use disorder in adolescents, followed by depression, which is a little bit different than what we think about anecdotally, however, still important. It's confounded by the fact that conduct disorder in itself is an independent risk factor for substance use disorder. It also perhaps doesn't recognize, it's important to recognize that ADHD is also included in the mental health diagnosis. I think what was surprising about this paper was that ADHD wasn't first, which is often commonly taught or commonly thought about. The other clinical theme I want to bring up is this notion about the importance of peers. That anecdotally, there's this term, birds of a feather flock together. In substance use disorder, that tends to be very true, as well as many other aspects of adolescence or social groups of adolescence. And I would argue that there's some theoretical reasons for this, but ultimately, I guess, to not get ahead of myself, this idea that in development, there's a shift of influence from adults and parents that shift of influence shifts to peers. And I think it's really relevant in terms of how we're doing interventions and how we're working with our adolescent patients. In terms of thinking about it theoretically, Erik Erikson, who's a German-American theoretician about development of personality, really has these many stages, these 8 stages of the development of a human from infancy to adulthood. The stages in his model that relate mostly to the chronological ages of adolescence are the 5th stage and the 6th stage. This idea that in the 5th stage, an adolescent's job, it's really, there's this identity versus role confusion of these principles, but what that means is like the job of a person in his teens or her teens is to develop an identity. And how we do that is we say, this is who we are, this is who we are not. And so that's the task at hand. The risk of not attaining that task is role confusion. And so arguing that much of that is based on, and again, social contexts and sort of filtering a person from amongst their peers. The 6th stage, which is young adulthood, we think about our early 20s, probably late teens, is about intimacy versus isolation. And so this idea about romantic relationships, intimate relationships, really connecting with others, another person. And the risk there, if that skill or that is not attained, is that of isolation, of loneliness. And so, again, in a normative way, like I know that a lot of parents are frustrated that their teens are no longer respecting them or taking what they're saying as gospel. And that they're actually asking their peers more. However, in a developmental perspective, these are, again, stages that are required to attaining adulthood. And a little bit of a segue, I would introduce this NIH graph about the prevalence of substance use in teenagers over the past decade. In an interesting way, what we actually see is a decrease in the prevalence of substance use all across the board. The only exception to this was actually vaping, which, because of its timeliness and introduction, had a huge peak, but then plateaued. And at the same time, it's important to recognize that the number of overdoses and the deaths by overdose in 15 to 19-year-olds, and just in the past year, has increased exponentially. Depending on the substance, anywhere from 400% to 95% to actually a 2,000% increase, and depending on the specific substance of overdose. And so, in some ways, this is contradictory data, but I think here really recognizes the fact that there are data and statistics that kind of relate to the general population. And within the general population, it's important to recognize there are specific populations that can be very vulnerable and have a different stratification of risk. This is a slide. So I had the benefit of watching a grand rounds by Dr. Joseph Lee recently at Duke, and he is the president and CEO of the Hazelden Betty Ford Clinic. And so he brought up this graphic, which is an illustration of an economics rule called the Pareto rule, or also known as the 80-20 principle. But that idea that many things are actually not distributed in a normal curve, that there are, in fact, perhaps a small minority of people who are it's employed in different ways. It could be like, it's a small, if we were talking about a business context, it could be in sales that actually just, 20% of the sales force are making 80% of the profits. If we talk about in a resource perspective or ED utilization perspective, we could say that maybe, 20% of the ED patients we're seeing are actually involving 80% of the visits. This idea that there's not a normal distribution. And so this is actually for adults. So I bring it up as like kind of a metaphor, but it's representing the volume of alcohol that's consumed and breaking it into percentiles. So in fact, just to highlight it, so the very top 10th decile, the top 10% is consuming this vast majority of the actual alcohol in the United States. So again, stating that maybe over a course of the full population, we see this decrease in use. However, there are high utilizers that are at risk. And in fact, psychiatry, much of the tradition of psychiatry is really attending to the vulnerable population and then the minority. If we think about risk factors, what I would bring up so what are the risk factors that can be just occasional or exploration use that then translates into actual substance use disorder, impacting function, impacting achievement and outcomes? Certainly family history is really important. And so always wanting to know about family history of substance use. Conduct disorder itself is an independent risk factor. ADHD is a risk factor. And as we mentioned, the peer association. So substance using, risk-taking peers being a risk factor for an individual to also adopt those behaviors. And then early age of onset. Even when assessing adults and their substance use, I think it's really notable. I always ask about what was the age they first had a beer? What was the age that they first used a substance? When I hear 7 or 9, which I've heard before, I'm like, oh, that's certainly notable. It's important also to recognize here that when we talk about adult substance use disorder, most generally, with just some few exceptions that I've come across, adult substance use disorder is originating in adolescence. And some people can talk about how there's certain stages of life when everybody was, well, and I can talk about this too, but where everybody was kind of using substances. And then the people that went on to have a substance issue were the ones that didn't give it up in their 20s. Just to segue or to add a caveat to that, my statement just then, the notion of everyone using substance use, I wanted to introduce that because I've forgotten. When we talk about the birds of a feather flocking together, there's a component of that too, where often when we're asking, there's studies about this, asking college students about their perceptions of alcohol use on campus, there can be this perception that, oh yeah, everybody's using alcohol. In fact, objective data suggests that that's not the case. And again, this just illustrates that when a person's using a substance, it may be that their peers are all using the substance and they have this false perception that everybody is using. And when in fact, objectively, that's actually not the case. Other frameworks, things to think about regarding these frameworks about substance use. So how substance use becomes problematic substance use and then impacting a person's life. Again, I'm invoking Dr. Lee quite a bit. If you ever have a chance to observe his talks, he's quite inspirational regarding this topic. So there's perhaps more useful frameworks of thinking about substance use disorders, and then there's some that are potentially harmful. The notion of common liability, this is a principle where there can be an underlying factor that then contributes to multiple manifestations. So a medical example would be the ways that obesity can contribute to both hypertension, prediabetes or diabetes, and perhaps arthritis. And so we have one thing that's contributing to multiple things in terms of the idea of substance use or other types of substance using, other types of risk behaviors, other outcomes, other psychiatric diagnoses, this idea that perhaps there's an underlying factor that's contributing to all these things. The stress diathesis model is similar, it's related. The idea that there could be a latent risk factor, whether that be heredity or some other thing that's sort of latent that doesn't get manifest until a stressor or an environmental factor. So that, again, reflecting on both the combination of multiple environment and then maybe some underlying risk factors. Two models that could be potentially harmful in just how we perceive or think about a substance use disorder are the gateway formulation or the gateway model and the self-medication model. So the gateway being this idea that, well, if a young person is exposed to substance such as marijuana, then that's causing irrevocable damage, and then it's going to lead to more and more hard use and then more destructive behaviors. In some ways, I think the risk there is a fatalistic approach, and the idea that damage is irreversible. I think that can be difficult from a therapeutic intervention perspective. The self-medication one refers to the idea that, well, the substance use is actually just a medication of the social ills or the poor life standing. I think some would argue that that's often commonly invoked, that a person just self-medicating with the drugs and alcohol. I think where it can be problematic is that it's treating alcohol and substance use as a secondary thing rather than primary, which probably is not in accord with what our evidence suggests. And then the idea that substance use is exclusively in the realm of people who are functioning poorly or have all these other problems, I think is the other problematic component of that diagnosis or that framework. And that also perpetuates stigma. And so again, I invoke all these as we're going to approach thinking about actual vignettes. And so in a broad overview, I wanted to introduce these three vignettes that are all real cases and have different aspects that I think can inform some of what we were talking about. So the first one will be M, who's an adolescent female that I've worked with for actually over the course of 3 years. They're notable because they had a much longer history of psychiatric concerns, and their development of a substance use disorder occurred during our care. And so it wasn't the first thing or primary thing that they'd come into care about. And in the course of our care, it manifested and caused some different difficulty, hence the title, The Conundrums. The second case, G, presented very differently, and my course of work with this individual is much shorter. And they presented with conflicts and behavioral concerns in the household and the suspicion of substance abuse, however, not a confirmed diagnosis and not the chief complaint either. And then number 3 was J. And so he was a little bit different, that he was already identified as a substance use disorder individual, or a person in therapy, a person in treatment. And he was referred to me for some additional medication management that could help his depression. So again, kind of difference in timelines, and then difference in some ways the formulation and approaches. And so, like to introduce M. I've seen her between ages 15 and 18. Initially, it was concerns about anxiety disorders and depressive symptoms. During our course of work, basically in the last year of our work together, she disclosed that she'd been using methamphetamine, and in addition to an increasing of cannabis use. Often we approach psychiatric diagnoses or formulations, and this is one model of doing it, the 4 Ps. What are predisposing factors? What are precipitating factors? What are factors that have perpetuated an illness or disorder? And then what are the protective factors? So I'll refer to the 4 Ps as we talk about the different cases. In terms of the timeline, or rather, this is background, some background about this individual. Their father did have a history of alcohol abuse and an alleged bipolar disorder. The father and the mother separated when the patient was in her 8th grade. And after that separation, she was actually estranged from her father and didn't have any contact. She was hospitalized multiple times between ages 14 and 15, kind of in the wake of the separation. SI, suicidal ideation, was the chief complaint. She'd been started on psychotropic medications, which incidentally had precipitated significant weight gain, which especially for young adolescent female, caused additional stress and stress with peers in school. In her family system, she had an older brother with a seizure disorder and developmental delay. She also had a younger sister, notably 8 years younger, which I think also had an impact on the principles of attention and just the dynamic of the family. In terms of strength, she was very creative. She had a lot of really pro-social behaviors. She was very normal in terms of her intelligence. I would say even bright. During her timeline in my care, there was a period where there was conflict between her mom and ultimately some risky behaviors around her sister, which motivated her to move in with her grandmother, who lived locally. Her grandmother worked full-time, and so because the patient had been hospitalized, she was in and out of school, and so it created a homebound school situation. In that context, when she was not being supervised by her grandmother, she actually invited boys to the home, and in that context, with a person that she liked, in sort of a date rape scenario, she'd experienced sexual assault. This made school actually quite worse. When she did return to school, it meant she had a lot of anxiety, acute stress related to the assault, and then ultimately she withdrew from school. And she was able to complete her GAD without any problem, which I think spoke to her intelligence and her cognitive abilities, changed the trajectory of her development. During COVID, it made a big impact on this individual in that without the structure or supervision of school, also without work, I think there was some precipitation of worsening of the social conditions and her psychiatric diagnoses. She did start dating a peer, and this peer was heavy into drug use and connected with other individuals that were heavy into drug use. In this period of time was also cutting, and her use of marijuana escalated quite a bit. In terms of thinking about interventions, the approach that I took with her was that of acceptance commitment therapy and motivational interviewing. ACT is a principle in which we're really, in some ways, trying to not minimize, but not lose sight of the reasons of engaging in care, which are not necessarily about anxiety, but about having a person restore themselves to a life that is worth living. In that vein, what are values that are important? What are things that are, again, important in a person's life? And that way too, motivational interviewing is also similarly patient-centered, and recognizing motivational interviewing, which I'm sure many peer have done some training in, can be really useful whenever there's ambivalence about change. The other aspects that came up in this case are just knowing where to respect the autonomy of the individual. So with adolescents, involvement of the parent can be a tension there. And so without involving the parent or having to hold and be aware of things that were in some ways dangerous, but also not pulling the trigger of needing to involve parent, which would be suicidal ideation or intent and homicidal intention. Those are the sort of the big things that in which we would potentially break privacy. However, at risk of sabotaging therapeutic alliance. And so that was a big aspect of just maintaining giving her autonomy and maintaining her privacy. Individual therapy was something I was advocating for quite a bit. And then we were doing a lot of medication management. I would say that with that as a caveat, and that the medication management was much complicated, likely in retrospect, very much complicated by substance using. And that if we're trying to do treatment for an anxiety disorder or treatment for a mood disorder, the fact that substances in the system, the fact that hangovers or withdrawal symptoms are making any day-to-day sort of presentation different, be very much about chasing targets, and it can complicate medication management quite a bit. One of the reasons perhaps that we have in some ways substance use is siloed in psychiatry, or that there's these dual diagnoses kind of facilities that in some ways recognizing the difficulty of treatment when active substance using is occurring. In terms of outcomes, I say this slide is a little bit complicated. Well, and before I go further, I guess I would want to highlight further that in terms of just elaborating more on the meds, she was on lithium, which could be helpful for self-harm behaviors and mood stabilizing. With the history of bipolar disorder in her family, I think it was one medicine that was actually the most constant that we did not change and probably was the most helpful. Alpha agonists can be used a lot in both PTSD kind of presentations and presentations when people are getting overwhelmed, in that it somewhat dampens the sympathetic nervous system. It also has an indication for ADHD, which is somewhat a concern for her as well. SSRIs are first-line medication for anxiety disorders and depression. And again, with her, this was a constant, although she also experienced many side effects from SSRIs that made it hard to see if there was any benefit from that. There was a very brief stimulant trial, and this is probably where the methamphetamine use that she was using and did not, before she disclosed it to me, probably complicated things the most. And that certainly stimulant trial was not helpful, but it was also in the context of methamphetamine, which is working on similar pathways and definitely contraindicated, or rather stimulant use would be definitely contraindicated regarding a person actively using methamphetamine. An atypical antipsychotic trial was used when she was hospitalized for suicidal thoughts that I did not start, but I continued for a period of time. And then this precipitated weight gain again, as similar things had happened in the past, hospitalizations when she was 14. And so then this was also stopped. Again, to flesh out some of the complications of the med management. In terms of outcomes, probably the most important thing was that was helpful was when she actually interviewed for a job and maintained a job for a short amount of time. The other aspect where, while I maintained her privacy, I think was always about encouraging her to be more open with her caregivers, with her grandmother and her mother, to encourage her and to trust in them regarding disclosing both the sexual trauma that she'd experienced, as well as substance use. And she was able to do that at a certain point when she was ready. And I think that was an important part of our care. As I mentioned in the past, she would also, this was complicated in that I don't know if we actually made a lot of progress. Certainly regarding the methamphetamine use, she did stop that, and I'll demonstrate some motivational interviewing that we did. However, I think when I first made this slide, there were some really good things going on in her life with the new job. And then later, that also, she lost that job and things kind of spiraled negatively as well. As an example of motivational interviewing that I use, not using the full, using sort of a set piece in motivational interviewing, what I'll often do is ask, what are the good things about the habit or the concerning behavior? What are the good things about using methamphetamine? Because recognizing a person's doing it, they're their free will. The example or the metaphor that's brought up with this type of technique of starting with so what's good is that it can be kind of disarming in the way that a tug of war when one person or one side drops the line, it can really be disarming to the opponent. And knowing that if we go in with the typical line of lecturing or telling a person all the reasons they shouldn't do something, the human nature is to actually tighten their grip on that behavior or to push back. And so, asking, what are the good things? And then following up with, so what are the reasons for change, or what are the reasons why you're considering change? The sign of good motivational interviewing is often hearing answers that we wouldn't expect or wouldn't come up with. Again, that it's coming from the individual, that they're volunteering it, I think makes it super important. And so in this process, asking her about it, like what were the good things, she described methamphetamine as being actually, helpful in terms of breaking the monotony. And I can imagine, again, in the context of COVID, this was like, it was fun, it was social. It also, was a context where she was using with other people. If we think about, again, the models for adolescents and the tasks at hand, well, actually, that kind of makes sense. When asked about what are the reasons for changing or the things she didn't like about it, she volunteered without even a hesitation, the mouth ulcers. I know that dentition and issues can be a concern, but I hadn't, been aware that mouth ulcers for her was such an issue. And she described every time she used, she would have these sores and they'd be painful. And okay, that sounds like a good reason to stop. She also described that the one friend who had supplied all the meth to this circle of friends, she found that he was particularly, I don't know, just shady is what she said. And that seemed important to recognize the complicated social interaction around the meth use. And so at the same time, she would say that, well, so she's more committed to not using the meth. She does also still want to use the cannabis. And so in that kind of context, with the motivational interviewing mindset, just embracing, okay, so what is about the meth that makes you want to think about it? Kind of ignoring the hesitation talk or the resistance talk. And then, trusting in the overall process. Some takeaways that I would highlight here, just the notion of autonomy. The ACAP, which is the Academy of American Academy of Child and Adolescent Psychiatry, emphasizes, for adolescents and substance using, privacy is actually really important. And again, this is about the therapeutic alliance. If we lose the therapeutic alliance, if the patient never comes back, well, we've lost, period. Recognizing the patient's strengths was really important in this work, that, she wanted to be an interior decorator. She's got this creativity. What are ways that we can, emphasize that? And then also knowing that actually our medicines didn't help so much. It was her getting a job, again, with the brief period of time that she was doing well, that was made the biggest difference. In retrospect, because ultimately she did kind of fall out of my care, I think what I would reflect is that maybe emphasizing her goals, I think embedded in that was, I would emphasize more the non-judgmental component. And not that I judged, but I think I was so excited about her interior decorating that when she lost her first job and kind of took a step back, I think it was really shame that prevented her from kind of re-engaging. And so again, I guess I would say when I first made the slide, there was a really good outcome. And then since then, she's actually no-showed and not engaged in care, not scheduled follow-up. And speaking with her therapist, I think that was a major concern. And so I'm hopeful that she can re-engage, but that is something I would want to mention. This is a slide from NIDA devoted to the principles of adolescent substance use. I use it to highlight the fact that it's a very holistic approach. So in addition to the evidence-based intervention for substance use, we have also family services, vocational services, mental health services, medical services, educational, legal, and HIV and AIDS. And so knowing that all these things are really important. Also to highlight here that with substance use, it's important to recognize that, one principle we could say that, substance users are not bad people. However, we also want to recognize that bad things do happen, that there are consequences that things happen. And so I bring that up regarding the legal services, regarding the reproductive health services that are really important. And so just recognizing that these consequences are also part of the impacts when we both think about adolescence and substance use. Vignette 2, this is G, 17-year-old, really brought kind of kicking and screaming by his father for these chief complaints of lying and impulsivity and suspected drug use, though at that time that was not disclosed and that he was not open to regarding to either to his parents or to me initially. So again, the 4 Ps being important. Here in terms of background, some suspected family history of ADHD in the family history. Both he and his parents invoked this one anecdote from when he was age 14, trying to make an argument for actually different things. His parents brought up this house sitting that he did when he was 14. His neighbors asked him to sit for their house the whole summer that they were gone on sabbatical. During that time, he invited his peers over and they would party in the house the whole summer. So his parents bring this up as an anecdote for demonstrating that very early on, he had these very impulsive and behaviors that didn't respect other people's rights. He brings it up because it was evidence that his parents just never let anything go. And they can't just forget that that happened 3 years ago. A lot of chief complaints about using the car without permission and stealing money, a very strained family dynamic. His parents are very professional, very educated, and comfortable financially. He has strengths of normal intelligence and also is quite athletic and involved in athletics at his school in an organized way. Regarding the timeline, he continued to have this ongoing parent-child conflict. He stole money and the car and went to a concert. He broke curfew. He would have friends over without permission, and his parents would get very upset about this. His family actually had voiced concerns that he was using anabolic steroids, had really attempted his pediatrician to test him, and his pediatrician was put in a very difficult position. He did get some testosterone testing as a proxy, but the pediatrician was really, asking me some questions about what the best thing to do would be. Regular school absences. Interestingly, he was able to improve his grades really quickly when there were consequences. However, he would still go to school late and miss school. Only when I was very clear with him that he had confidentiality, and only when I invoked the structure of the sessions that he could meet and then separately from his parent, and then I would meet with his parent, but I would not disclose anything he said to his parent without his permission. Then he was able to disclose to me much more openly once he believed me on that. I would say regarding the 4Ps, in terms of predisposing factors, I do think a family history of ADHD and perhaps ADHD concerns with him were predisposing factors. Precipitating factors, it could have been involvement with peers, it's hard to say. Perpetuating factors seem to be a lack of care or lack of openness, a recognition of what was the disorder. And then some protective factors I mentioned in terms of both financial stability, academic, she's not academic so much, but innate intelligence that was sort of a help, as well as his athletics. For this, I'm introducing the notion of a screener. Again, like just meeting him, I wasn't sure how to make sense of his substance use or concerns. This is a craft that's meant to be open without a proprietary cost to using it. And what's important to know is that a lot of screeners we use for adults actually don't apply so well or not evidence-based for adolescents. With the CAGE, which is often used, the E, which stands for eye opener, often really lands wrong with adolescents. Adolescents will, they won't talk about an eye opener after a binge drinking. In any case, this is part A of the improved version, asking for use in the past 12 months regarding alcohol, marijuana, or anything else to get high. I would note here that a good screener for adolescents also recognizes that there's so many other possible substances that a person could use to get high. That's been a challenge of the FDA or a challenge of regulatory bodies that to keep up with synthetic cannabinoids or new practices in substance use is actually quite a challenge because things can evolve so quickly. Regarding the B, part B of the craft, questions about have you ever ridden a car? And maybe I can answer this how he answered it. When I asked if he's ever ridden a car driven by someone who was high, he sort of disinhibitedly said, "Oh yeah, all the time," before he kind of understood what we were actually doing. When I asked him if he used drugs to relax or feel better about himself or fit in, he went on sort of a longer kind of almost tangent about social groups and what it means, and in some ways gave me a more complicated answer. Do you ever use alcohol or drugs while you are by yourself or alone? I think he denied that. Do you ever forget things you did while using alcohol or drugs? He denied that as well. Do your family or friends ever tell you that you should cut down on your drinking or drug use? He admitted that his family was, even though they just suspected his use, it was very much positive for that. And then if you'd ever gotten in trouble while using alcohol or drugs, again, he was giving me this complicated answer, and I had to be clear, well, it's not about actual legal stuff or actual discipline, but was there something that, privilege that he lost or some conflict? And he admitted to that as well. Based on how we would sort of triage or risk stratify, certainly this individual was in the category of high, in that he admitted to using in the past 12 months. And he also rose a 3 on the craft. What we talked about in some ways was substance abuse in terms of advice. This was an individual where I was clear with him that, like, no, actually not everybody drinks or uses. It's probably like your peer group does. And he was actually able to admit that that sounded true. Again, following up, and as a psychiatrist, that was my job to make that a target of care. Other screeners that are really validated and easy to access, BStat and S2B1, or S, I'm not sure if that might be an I. But this is, there's a NIDA website that has this, like, it's 2 minutes, the website pulls up, it's a click and sort of automated process. It can be really helpful. The difference is that BStat emphasizes the number of days, whereas the other one is about the frequency. Both can be really useful regarding how we screen. In terms of this individual, the timeline, we did some formal testing for ADHD. He actually was positive for inattentive type. And then we discussed carefully the risks and benefits of stimulants. In general, using agents that are going to be low risk for abuse steered us towards the long-acting. So the idea is that if there's a long-acting agent, very few people will take a medication to get high 6 hours later, rather than something, in 30 seconds. And so that's important to recognize that and being clear about those boundaries. And then ultimately he reported like side effects from the Concerta, the methylphenidate ER. We did switch to Vyvanse, and I did do a family therapy referral, which he refused to participate in. We did MI quite a bit, which with interesting responses. And he again described the social component being a real motivator for use of the cannabis in the past. And then was able to admit to the family discord as being an issue. Over time, with the addition of the stimulant, we did see a decrease in problem behaviors. He was ultimately accepted to college. He started having more structured days with playing in the spring season, preferred sport. And really what I was emphasizing with the family was the notion that, this is about, right now is better, but it's really about what are things going to be like in college when there's not that supervision. What is it going to be like? And for the parent-family dynamic, what is it going to be like 10 years from now when he doesn't necessarily need to be with family? Like, will they be able to have a healthy and relationship? And so those are things that I continue to emphasize with them in ongoing care. So to fast forward a little bit regarding this last vignette, this is a 16-year-old who was already involved in treatment for substance use disorder, intensive outpatient treatment. And that was referred to me for history or concerns regarding depression. He did have a predisposing factor regarding his biological family. He was adopted at childhood, but his biological mother did have some concerns regarding both mental health as well as substance use. Unclear what were the precipitating factors. Perpetuating is likely COVID. There was really not a social setting that I think he was reinforcing to him or pro-social that was healthy. And protective factors, I would just say that he was very likable, very funny individual. And so again, COVID kind of casts a shadow on this era of our treatment, in that he was engaged in outpatient treatment or intensive outpatient, but it was all by telehealth. Also, part of this was tobacco cessation. He was using a lot of nicotine, and so we did do an intervention with nicotine patches, which was helpful. We made a lot of adjustments regarding depression treatment in terms of SSRIs, SNRIs, so sertraline, Prozac, perhaps venlafaxine, if my memory serves me well, without much benefit. And that was really a challenge. The one thing that was helpful to him was the alpha agonist, which was kind of a constant thread, because he was prone to these episodes of explosion and getting super overwhelmed. And though he had a very caring relationship with his parents, he would have these outbursts. Given his history of ADHD, he'd been on stimulant in the past. We did trial a stimulant, however, it was not helpful and again complicated by substance use. When we saw a real downturn, in some ways there was a period of maintenance that was happening. He would engage in care, however, then there was a real downward spiral. He was cut from the football team for a lot of sort of back talk and what was perceived as disrespectful behavior. And then he started using in an active way. In our actual sessions, he would present high and really altered, and that would make it very difficult to have a meaningful therapeutic relationship. He was ultimately referred to residential treatment, so a 40-day program. And in that care, he actually, well, initially had a very bumpy time and was using and had swallowed some alcohol pads in his very first days being there, and then ultimately kind of showed some significant improvement in terms of engaging in the 12-step program, being able to connect with peers. And I remember telling him that, in our last appointment before he was going to inpatient residential care, I was telling him, you're going to meet some really cool people, to be honest. And my experiences clinically and training on an inpatient unit where people are there and they're serious about care and have a history of substance abuse, they tend to be hilarious. They tend to be super smart. They tend to be super interesting. And so I gave him that heads up. And ultimately, he did really well there. When he returned to a sort of a step down kind of care, which was intensive outpatient, but in person, he also went to an alternative schooling program once that ended, and continued in his outpatient maintenance kind of appointments with his 12-step program. He continued to do well and continues to do well now. When I asked him about this talk I was going to give, and I just read his feedback, he shared that, again, without a stop, was that when we were doing our appointments, again, we were doing our appointments at the time by telehealth, he said that it was actually probably important that he meet with me separately from his dad. And at that point, I had said this is the structure, and he'd insisted, no, he could be there with his dad. In retrospect, it was because he didn't want his dad to think that he was hiding things from his dad. And he admits later that he asked me that maybe I should have held that frame and insisted that he meet with me because it was important to kind of disclose some things. In terms of the substance use treatment, pharmacotherapies, there's actually not a lot of great data. There's some pilot studies for naltrexone and opiate use, ondansetron, disulfiram and alcohol use, and then they're just pilots. Buprenorphine is FDA approved as an opiate replacement or maintenance for opiate disorders. Nicotine replacement in this case, certainly has some indications and some use. But it's the nature of a lot of adolescent psychotropic medications. We don't have the studies to power them at this time. And then there's this interesting study where that was just published by Dr. Curry here at Duke, that CBT for substance use in adolescents in itself actually helped depression outcomes. And so I invoke that thinking about this case, and that all we did trying to manage his depression symptoms with meds was actually not fruitful. And when his substance use was more meaningfully treated, his depression resolved entirely. And we were actually really backing off on medicines at this point. And so I wanted to step and here and open it to questions, and here's some references. I will stop sharing the screen in order to invite a discussion.
So we do have a question. How do you handle parents who want to drug test without the teen's consent?
Yeah, so I think that's it's a great question. It's really complicated. Ultimately, there's a practical component where we're not going to be able to, without, forcing a person. And so often there's external components or aspects, so other privileges or an understanding that in order to do this, then a drug screen needs to be provided. When we talk about actual substance use specific treatment, such as intensive outpatient, or basically treatment care plans that are designed around substance use, that's also built in. So if a person's engaging, they're already going to have to be consenting to that. But if we're talking about sort of a suspicion level or screening level, I think it does enter a power struggle, which is in some ways practically impossible to win. In that compelling a 17-year-old, a person to somehow give urine or give blood against their will is actually not going to happen. And so I mentioned that because let's just be real about it. And so what happens then is okay, can we set up a paradigm in which the patient is going to consent? If they want to do this, then they have to give this. And that's the understanding going into it. And that's probably more helpful. The second case I mentioned with G, that's the dynamic. I think why I mentioned G was that relationship was so toxic, right? A mom, venting and losing, and being so frustrated that her kid is doing this, that the trust was so impaired, was basically burning bridges on all sides and making the kid more resentful. So that's what I would invite, is that it would be about an understanding and some sort of agreement with consequences if it wasn't complied. And as often if it's getting to be a really high level of concern about substance use. It's often about that higher level of treatment where that's involved as a part of the designed plan.
Thank you for that.
One of our, just as a funny anecdote, one of our IOP clinicians he would get ribbed by the group because he'd be like, "Oh, you mean the guy who carries around, who collects all our pee every session," and kind of giving him some grief about it. But that was kind of what it was. Like he would, have his little pee collector at each session.
Okay. Do you ever suggest the parents do an over-the-counter home test if they insist they want a test?
So I'm not familiar with the products that are available. And so actually I can't responsibly answer that question. And I guess so you're saying if the patient, if the adolescent, or the child is consenting, then would I recommend a product? I think the first part of the question, if you have the child's consent, then I think that's reasonable. If the product is reliable, which I imagine there might be some over-the-counter ones, I would just have to review the labeling and sort of the evidence.
And then we have another question: how do adolescents who are in drug treatment take it seriously when they're being court mandated?
Yeah, so the court mandate, I think, is a great thing to bring up. And it's one of these realms where what legally happens and we see in the world and what clinically is evidence-based or supported are sort of like incongruent. And so often, we think about mandated therapy for other legal things, and basically and I'd have to review actual papers and things, so I can't do that. But I think my general clinical training has suggested that court mandated things are really sort of a quasi punishment that ultimately doesn't have the outcomes that we would want them to. And it can be, that way it can be a little bit complicated. So your question, the bigger question, how can I encourage an adolescent to take anything seriously? Probably that's probably very difficult. Where it's built on other contingencies or things that the adolescent is wanting to do, is really where it's going to be important. And then this comes back to the other sort of that dynamic, the power dynamic, the idea that an adolescent listens to adolescents, which is where a peer-based 12-step group or peer-based intensive outpatient can be super powerful when they see people who are saying, "Hey, no, this is okay, this is cool, this is what I'm doing, this is how we connect, and this is this is reasonable to do." When it's sort of like a top-down structure it really just invites a lot more rebellion. And so if there's a way that there are other kind of allied sort of interventions, such as multi-systems therapy or multi-systems treatment, which is indicated for conduct disorder and ODD, which involve the whole system. And that is a proprietary intervention, which is akin to intensive in-home, but involving representation in the school, legal, home, and it's basically about consequences. In a way, I characterize it as the inability to avoid the consequences is what promotes the behaviors that we want to see. And again, that speaks more to the conduct disorder comorbid with substance use.
Thank you so much. Another question: any thoughts on primary care docs doing Suboxone treatment in their offices?
Yeah, I think that's reasonable. There was actually a paper I was reviewing for this that said that there's evidence that supports that has a meaningful impact on outcomes, and is not beyond the scope of a primary care physician. Part of the reality is that we have so few psychiatrists, we have even fewer child psychiatrists. Mental health care in this day and age is being done in the primary care situation, which is why I'm so appreciative to these kinds of forums, to be enriching and adding to a clinician's confidence and their arsenal in that realm. And so actually, I think that is a very reasonable thing. I know that there's still going to be barriers regarding what clinicians feel comfortable doing, and what they feel like they can accommodate. The Suboxone training is fairly reasonable, and certainly I think the benefits would outweigh the risks in terms of Suboxone. Other things that are also what we call So mediating outcomes, mediating bad events include, naloxone, the dissemination and the reception of naloxone in the community. I think, there's all these other measures that can be helpful. And that's really the question. Is it going to be helpful to preventing overdoses, to preventing and to fostering better outcomes?
So we want to thank you again, Dr. Cho, for your presentation.
Yeah, thank you. Have a great rest of your day.